No, that way. Okay. All right, everybody. Good job. First group, it's not easy being the first group. Okay, so let's talk about some things. So we came in, and what did you two assess on the patient?
What the site looked like, her pain.
Did they
If
assess
she
the
was-
color?
I think yes.
Go ahead, Beth, let me finish. I'm sorry.
Color. Stiffness, if she could feel it, which obviously she could with the pain. That's about it.
Okay. Now you said color, Joseph. Did they assess the color? What color did they assess?
I think they talk about palo or something like that, but probably I didn't hear them well.
Okay. So you think maybe it's something about pallor? What, did they miss anything in the assessment?
Yes.
Yes, you say yes, Sandra, what?
The color, and also probably can ask the patient to play with, try to,
Range
yeah,
of motion,
not the range of motion, but,
level of consciousness.
to play with the toes, to see you can move the
Paralysis.
toes.
Oh, so to check for movement,
Mhm.
okay,
Also
good.
can ask the patient, could you try to see if you can, like,
Push down
push
on your
down with
hand
my
as
hands,
Okay.
or
hard as you can.
classification, something like that to see.
Okay, good.
And also check the sensation, like if the patient feel you when you touch on the, if there's
And like
any.
the circulation to see if the cast is too loose or tight around the area.
Okay. Does she have a cast?
I mean, not a cast. I'm sorry.
But we do wanna check circulation, and where do you wanna check circulation?
Distal
Or
to
feel
To the site.
the side.
Excellent job. Distal to the site, so did we do that? Did we do that?
I don't think so.
Okay, all right, good. What else? What else? So let's talk about the pain assessment. So we did the pain assessment.
Yeah.
How do you all feel about your pain assessment? You feel like it's pretty thorough pain assessment? Sounds good.
No,
Well, why not?
because we should have asked like what the onset was and how long she's been in pain. Like those kind of questions.
Good. What else is important to know? Cause you did really good in asking, I believe you asked about pain scale, correct?
Mhm.
So we did a good job asking for the numeric pain scale, but what else do we wanna know about that? For follow-up, for instance.
Probably ask the patient, when was the last time you received pain medicine?
Mhm.
Well, we
What kind of
already asked
medicine
her
is
that,
it?
we
Yeah,
asked
she
her that, and she
couldn't
couldn't say. So we looked in the computer and it was an hour, so grandma get a little bit addicted to those tramadol.
Now she's addicted to tramadol. But what's another way for us to objectively know how our treatments are working?
Her face, her grimace, if she grimace.
Mhm. But specific to the pain scale that you used. So of course, when I ask
No,
them
let me,
what the
she
pain
said
level
a
is.
7, so
Okay,
what is a 7 in your words? Cause, you know, a 7 can be very dependent on the patient.
that's true. But when I come back, so I'm gonna come back and check on the patient. When I come back to check on the patient, what's one way that I can know if this pain medicine or whatever intervention I did, whether it's pharmacologic or non-pharmacologic, if it's working?
Her facial expression, and if she restless or not,
Okay,
because most of the time when they're restless, they're probably in pain.
they could be, or she could have chronic pain and she could not have facial expressions at all. So we're talking about numeric, of course, we wanna ask them to rate their pain, but then you also wanna know their goal. What's your goal pain rating? Now, what if they tell you my goal is 0, I don't want any pain?
Try to explain to them that that's probably not gonna be possible right now.
Very good. So talking about what's realistic. Excellent job, very good. What else with the assessment? So we said assessment of the surgical incision site. Anything else?
How her activity's been.
Okay. And there's another big important one, but we'll see if group 2 gets it. But good job, group 1. It's not easy going first. Okay, so group 2, you're up next. You're up next. So same scenario. We have Miss Carolyn Hazard. Her preferred name is Miss Carolyn. 76 years old. Post-op day 3 from a left hip arthroplasty.
Knock, knock.
Come on in. Good morning.
How are you doing today, Miss Caroline?
I'm so.
This is Sandra.
And I'm Joseph. We're gonna be your nurses today. I heard you 3 days after your surgery, so we're just coming in to check how you're doing. Are you in any pain at the moment? From on a scale of 1 to 10, 1 being the lowest, 10 being the highest.
Yeah, I'm feeling some throbbing there where that surgery was.
Okay.
I guess I'd call it about a 7.
7. Okay.
Okay. Anyway, have you taken any medication for the pain before now?
When was the last time you had pain medicine?
I think the nurse may have given me something before you came in. I really can't remember.
Okay, we can check that one later. Can we see the place for this for the surgery?
Please don't touch it. It's so sore.
We're gonna
Okay,
be
we're gonna
soft
be
and
careful.
gentle. Alright, we're gonna assess the skin.
Can you press down on, can you wiggle your toes for me?
I could do a little bit.
Can you
Okay.
press down on my feet? As hard as you can? Feel it?
Okay.
Check your
Alright.
stuff.
So, Miss Caroline, do you live by yourself or you live with family?
I was living by myself before this.
Okay, all right. So, we understand that you already give the pain medicine. So you're gonna have some other people gonna come to help you. Physical therapy gonna help you to, get back and use your.
Yeah, but now we're gonna try, since you had a medication 30 minutes ago, we're gonna try some range of motions, move that hip around, get you moving better so it won't stiffen up on you. So let me know if I move you, you feel any pain or anything. And we can stop at any time.
Ow!
Okay.
All right.
I'm gonna stop.
Okay.
Now, I noticed you said you were in pain instead of 7. Do you have a goal to get that pain down?
I mean, I don't want any pain. Who wants to be in pain?
Well, that's
We know definitely you're gonna be having some pain with this surgery. So
It's gonna take a little while before you're gonna not feeling any pain, but for now we're gonna try to keep the pain as low as possible.
at least about a 2, get it down to a 2 or a 3 for you, or whatever that may be. And then we're gonna go to therapy that's ordered for twice a day to keep you moving, so when you discharge, you can be able to move around and do things at home and do things with your family, but you still gotta take it easy and be careful when you're doing things.
Okay, let's say that you all went back to the MAR and you noticed that her pain medication actually was given 4 hours ago and she can have it every 4 hours as needed, and you administer pain medication for her breakthrough pain. And so now we've come back, it's an hour later.
To assess to see how she feels if the pain is lower than.
Okay, so talk to your patient. So it's an
Okay.
hour later, it's an hour after administering that medication.
We coming in to check and see how that pain medication feeling. Can you rate your pain on a
From the
scale
last time, how do you
1 to
feel?
10? 1 being the lowest, 10 being the highest. You said it was a 7, which was like medium. Where you be at now?
I'm feeling a little bit better. I guess I say about a 4.
Oh, that's really good. That's improved. Are you ready to try any range of motion now since I'm back in here?
What's range of motion?
Well, any,
Trying to exercise the joint. If
Yeah,
you be able to move it better.
Well, the doctor told me I can't move my leg.
We're gonna support your legs, we're gonna help, so.
we're gonna put pillows on it so we can get that pressure off that hip. So you're gonna have some,
But you've got this pillow in the way. How am I supposed to do it? Can you move this pillow out of the way?
Okay, we can take it away, man.
take it away.
So,
So what should I do? Should I?
Now, we're just gonna support,
Your
your
hip,
hip,
so there won't be any pressure on it.
and then we're gonna try to move to play a little bit to help, the sleep and maybe help the knees and for the circulation, that's gonna help, the hips to heal and,
The heel, then
quickly
you get
and
more
get-
active and your body can get used to it since it's something new.
and then, what else? Okay.
and with the
You
color,
did
with the
good.
color of your skin, we can see there's good circulation.
All right, thank you, Miss Caroline, thank you, we're gonna come back later on to check
on
on you,
you,
if there's
okay.
anything you want else from us, well, please stay in bed, I'm gonna put your call light, your,
And before we go, Miss Caroline, do you have any question for us?
No, I don't think so.
Okay,
Alright.
thank you, man. We'll be back again to check on you.
Very good. Okay. All right, group 2. How'd you feel about that?
That's pretty good. I would just change, like when you said the doctor didn't allow her to move the leg, I would just have them explain like more of what movements she can do
Mhm.
and that kind of thing,
Mhm.
cause they didn't really address it, but that's good.
What about when she said she wants you to move this pillow? And you guys just took that pillow? Were you simply
You
just
have to
moving the
see what the
pillow?
order is.
Okay.
You cannot move because the pillow is there for a reason.
Okay, so why is this pillow here?
to support.
It is to support her hip
For not to put too
to
much
prevent
pressure on it.
dislocation of the hip.
Okay, so this is a hip abduction pillow. And why do we want to keep her hips abducted? What's
So
the
that-
purpose of this
You know,
pillow?
after the surgery, it had to be,
Remain,
it
in
had to be,
position.
Okay. So what's the purpose of it?
The joint could be
Wanna stay in place?
place
to
and
stay on
heal,
position.
because if it's like this proportional,
Okay, good.
it won't be, it could have a deformation and it won't be like, the result that we're looking for is not gonna be.
So we don't want to dislocate that
Yeah.
new hip. So this is there to prevent the patient from doing what?
Moving.
From moving?
No,
Do we want her to be immobile?
No,
No.
we want her to move.
We want her to move, but there's restrictions to movement, right?
To keep
So
the
what-
hip aligned.
Right, so it's to keep her from crossing her legs. That's the purpose of the abduction pillow. So how could we address her saying, oh, this pillow is really irritating me, can you move it out of the way?
We can explain the purpose of it.
So I'm the patient, tell me how you're gonna explain that to me. Can you move this stupid pillow out of the way, Sandra? It is wearing me out.
Well, Miss Caroline, I know you probably don't feel comfortable with the pillow, but we put the pillow that's gonna help your hips to stay in place, and it's gonna help not to put too much pressure on the hip. So I can try to adjust it and make you feel a little bit more comfortable, but I cannot remove it.
Okay, good. And making sure that we're explaining the rationale. The purpose of this pillow is to make sure that you're not crossing your legs, because we want that hip joint to heal properly. Okay, very good. So let's talk about the 3 Ps, because remember I said that, so we talked about the 3 Ps with compartment syndrome, which is a complication of what? Compartment syndrome. If the patient had a what?
Okay.
A cast, very good. So we talked about that, but remember I said also if the patient has any sort of surgery, right, like having a hip replacement, then we want to check the 3 Ps. And let's talk about if we've done that. So what are the 3 Ps?
The pain,
Pain,
Pillar.
pallor,
Color.
paresthesia,
Postless.
postlessness,
Paralysis.
paralysis.
Poikile, whatever.
Very good. Poikilothermia, which is what?
That's called.
Cold to touch. Okay, so do we feel like we did all the 6 Ps?
Yeah, quickly.
Okay, so we did assess for pain, all right? This patient was really good about explaining or kind of describing what that pain is. But if you came in and she said, oh, I'm just hurting, what might we say or ask to follow up?
Where are you hurting?
Right. Where exactly is your pain? What else?
What kind of pain? What kind of pain?
Can you describe the pain for me? Very good. Were you doing something before the pain? I think first group asked about if they had physical therapy, and then start having this pain. So that was a good question because that tells us alleviating factors, right? And then we can ask that tells us aggravating factors. So then we're gonna ask about alleviating factors. So how might we ask that question?
Is there anything you're taking to alleviate the pain?
Very good. What's been done so far that's helped your pain the most? Okay, because you might be surprised. It may not be medication. Maybe it's reposition.
Okay.
You know, if you can just help me get reposition, I think I feel a lot better. Okay, so asking those alleviating factors, right? So that's pain. How do we assess for pallor?
We check the skin of the color of the skin.
Very good. So we're using inspection, right? So we're gonna check the color of the skin. And of course, while you're doing this, and you're gonna let the patient know what you're doing because they may be tender, okay? Especially if you're close to that incision site. But as you're inspecting, you can also be what? Palpating. So all of these things you could be doing quickly because she's already told you that she's in pain. And we do want to address her pain. And so we can do that assessment pretty quickly. So it may look something like this as she's telling me about her pain. So how would you rate your pain right now? Okay. Oh, I'm so sorry that you're feeling that way. What is gonna make your pain feel better? What activities or what things have we done here that have made your pain feel better? Oh, sure, I can definitely help you get repositioned. I was looking over in your chart and I see that the night shift nurse gave you some pain medication right before the start of the shift at about 6:30. How are you feeling right now? Did that pain medication help? Or are you feeling worse? Or are you feeling about the same? You all see what I'm doing? Okay, I just pretty much just did the 6 Ps with the exception of checking for sensation. Okay, so as she's answering those questions, then I may say, okay, are you able to wiggle your toes for me? Very good. Can you press down with your feet against my hands? Good. Can you press up towards your head? What else do you notice about how I'm assessing? So I checked pedal pulses, and I checked behind the ankle, which is what? Posterior tibialis. And what do you notice about how I'm assessing? What do you notice?
Simultaneously, all together at the same time.
At the same time. So I'm checking bilaterally. Why do I care about checking the right foot if she has surgery on the left?
Probably it has the same.
Very good. So we want to tell the difference, right? We want to see if she's like weaker on the left side, if the pulse is less bounding on the operative side as opposed to the non-operative side. And you're doing the same thing on when you're checking for color, when you're checking for temperature. What else can we check that I didn't see anybody do to check circulation?
If it's cold.
So that's the capillary refill. Very good. And what should that be?
Less than 3.
Less than 3 seconds. I'm gonna check bilaterally. So whatever you're doing as it relates to checking for pallor, so when you're looking at color, when you're palpating your pulses, all of those things, you're make sure that you're doing those things bilaterally so that we can get a comparison. Okay, when you're checking activity and motor function, you're doing all of those things at the same time. Okay, any questions about that? Okay, now let's talk about, there are a couple things that I wrote down that I want to talk about as well with this. last time pain meds were given, and both groups did this, I wanna talk about it. So you asked about, so tell me about the assessment of the last time meds were given. Tell me about how you assessed the last time medications were given.
We ask the patient.
You asked the patient. What do you think about that method?
I would have looked at the med list before I even got to the room.
Good. Why? Is it because we don't trust the patient?
Because the patient can say, no, you didn't receive anything. Or maybe not remember.
Or maybe not remember. She just had surgery. I don't know if any of you have ever been hospitalized, but you can definitely get day and night mixed up. You can get times mixed up. You may wake up and think, and I've done this before. I was in the hospital on bed rest for several weeks with my last son, and I would wake up and I would swear it's 6 p.m. or 6 a.m. and it's the opposite time, right? Because the days and times and like your circadian cycle can be really off. So what's a way that we can verify? We can always ask the patient, but you always want to verify. Yeah, so taking a look at the MAR and not necessarily asking the patient. So we can say, oh, okay, I'm so sorry to hear that you're in pain. Let me take a look at your medication list. And I go back and I see that they had medication an hour ago. Then I can say, because Saskia did say, oh, we had medication an hour ago. And then she said, we had medication an hour ago. How do we feel about that approach?
No. But I offer her Tylenol.
You did offer her an alternative. But what's the way that we can communicate to the patient?
So I would say, according to the MAR, you had some tramadol an hour ago. So, and you get it every 4 hours PRN. But if you're in pain, I cannot give you the tramadol, but you have a PRN order for some Tylenol. Would you like to have some Tylenol?
Very good, very good. So we can see if there are other options available. We can also try non-pharmacologic ways of reducing pain, like what? Breathing exercises, repositioning the patient.
Heating, cooling.
Yep, heating, cooling, if not contraindicated, because some patients that be contraindicated for. What else?
Is distraction could be
Distraction. Good, good. Depending on the pain level though, so how will we decide what to do next? Because she just had her PRNs an hour ago. Let's say she had her PRNs an hour ago. She's not due for her PRNs for another 4 to 6 hours. But her pain hasn't changed from the last time that we have given her pain medication.
I would ask her if she probably would like something to eat, to drink, the TV on, the radio on.
Okay, but her pain is right now at 8 out of 10.
Call the provider.
Yep.
There we go.
Yep.
Maybe we need to have a conversation with the provider about her breakthrough pain. There could be some underlying issues that we don't know about, that she's still having this much pain. Now she is post-op day 3, but we should be seeing some pain relief with the medications that we're using. So if it's an hour later after taking a pain medication, let's say she's getting oxycodone, Q4 hours as needed for pain, and she just got oxycodone and she's still, the pain is worse or not better,
That means there's something going on.
then there could be something else going on. Maybe we talk to the provider about it, but we could also take a look at what? Because it may not necessarily be anything underlying going on, it could be what? Especially if the
infection?
medication is PRN, what could it be? What do you think? If the meds are PRN?
She probably took, maybe we can ask to schedule the pain meds.
So they may not schedule it, we can talk to the patient about what kind of education can we give our patient? Because she's 76 years old, and believe it or not, and I've seen it with my own eyes, I've cared for 16-year-old patients that came in with an ankle fracture, and you would think that they were giving birth to twins and have been pushing for the past 36 hours because they were in so much pain. And then I've had a 90-year-old patient in the same day who's like just had open heart surgery and is refusing medication.
Refusing?
Yes, because they don't want to bother you.
So,
Oh dear, I know you're so busy, I don't want to bother you. So what kind of education can we give our patient?
I would say, like, you don't bother me at all. I'm here for you.
Mhm.
And do you mind to let me know before the pain becomes so severe, you tell me that you in a little bit of pain so I can try to give you some medication so you don't have to be in this type of pain.
Very good. So we're doing that education so that we're not what we call chasing the pain all day or chasing that pain and they're always in pain, so that we can try giving it more regularly. So we can take a look at when was the last time they had pain medication before that, when they got it an hour ago. And then we look back and see that they had not had any pain medicine for 8 hours prior to that. That could be one of the reasons too. So you're gonna look at the history and see. It's a different story if you're getting it pretty much every 4 hours on schedule and you're still an hour later after this, you're still complaining of 8 out of 10 pain, okay? So taking a look at all of those things plays into the clinical judgment as well. All right, good job. Are there any questions about that? Okay. And then of course, patient education and thinking about what that looks like for our patients is gonna be really, really important as well. I have to take this is my son's school, I'm so sorry. We can pack up and go to the next room.